Great. Thank you, Di. Morning, afternoon, evening, everyone. Thank you all for joining our webinar today. My name is Chris Sampson. I'm based at the Office of Health Economics in London, in the UK, and I'm a convener for IHEA's Mental Health Economics SIG. We organise activities around research and education in the economics of mental health, and we try and connect researchers interested in this topic. So if you're not already a member of our special interest group, please head over to the IHEA website and join us. We've organised numerous webinars over the years, and you'll find recordings of those on the IHEA website. As Di said, the recording of this session will be made available. So the topic for today's webinar is the measurement of mental health. Economists have their own preferred approaches to measurement, but it's a diverse area. So I hope we'll be able to pick up on several strands of research today. The format for today's session is somewhat novel for our webinar series. So the whole session will last an hour, as Di said. And then during that time, we'll hear about research studies from 3 early career researchers, each of whom will have up to about 15 minutes to present. And then after that, we'll have a discussion of all of the 3 studies led by a discussant. So I'm pleased to say that we have 3 excellent researchers with us today to present their work. We have Rachel O'Loughlin from the University of Melbourne in Australia. We have Sam Perry from the University of Birmingham in the UK, and Tao Tai from Monash University also in Australia. So an Antipodean affair today. And we're lucky to have Tessa Peasgood as well from the University of Sheffield as our discussant. Before I hand over to our first speaker, as Di said, please use the chat function. We won't have a formal Q&A as such at the end, so don't wait to share your comments. Get them in soon if you can. Final word from me, I promise. At the end of the webinar, I'm going to post a link to a survey in the chat, and we'd be very grateful if you could complete that survey for us before we all sign off. All right. Thank you for enjoying my introduction. I'd now like to hand over to our first speaker. Rachel, over to you.
Thanks, I'm just getting my slides up. Hoping you can see those okay now.
Yeah, we can see that fine, thank you.
Perfect. Just get that. Okay, so thank you for coming everyone, and thanks for joining today. My name's Rachel O'Loughlin. I'm a research fellow in the Melbourne Health Economics Group, which is based at the University of Melbourne in Australia, and I'm delighted to share with you today some of the work I completed during my PhD last year. So this work was examining the validity and reliability of generic health-related quality of life measures in child and adolescent mental health. So I'd like to acknowledge all the people in this meeting with lived and living experience of mental health challenges, and either their own mental health or caring for and supporting someone that they love. I want to also acknowledge my co-authors on this paper, the study project team, so the Quantifying team, and the funding that supported this work. So mental health and substance use disorders are the leading cause of disability in children and young adults worldwide, accounting for 1/4 of all years lived with a disability. In a recent report in Australia, we found that 40% of children and young people aged 10 to 24 years suffer a serious mental health problem each year. Despite substantial investment into the prevalence of mental health conditions in children was unchanged between 1998 and 2014, and that prevalence has actually increased by 50% since 2007 to the current period. The most common mental health disorders that affect Australian children are ADHD and anxiety disorders, followed by conduct disorder, depression, and other disorders. Childhood mental health disorders are associated with poorer outcomes throughout childhood and adolescence, but also into adulthood. So that includes things like educational attainment, relationships, employment, criminality, earnings potential, and workforce participation. So in 2021, the Australian government spent $11.6 billion on mental health related services, and this number is increasing over time. A large proportion of this increase was for youth services, with that spending increasing by an average of 14% per year compared to about 2 or 3% for general services. Youth services also cost more to run than services targeted at the general population, with a cost per patient day of about $2,000 compared to about $1,000. So here in Australia, we're spending more and more on mental health care, but that isn't translating through to a reduction in the prevalence of mental health disorders in children. Health-related quality of life is a construct that captures the impact of a person's health status on their physical, social, and psychological functioning. So that can include things like pain, mood, mobility, daily activities, and in children it also includes things like school functioning and self-care. It's well recognised that early life mental health problems have a substantial impact on quality of life, and information on children's quality of life can be used in research and clinical settings to compare the relative impact of various health conditions on the children's lives, and to identify groups of children who are at the greatest need. In addition to this clinical importance, quality of life is one of the key outcomes used by national health bodies all over the world as a measure of the impact of services and interventions on people's lives. So that forms the basis of judgments about the comparative value of these services and interventions. There are a large number of instruments available to measure quality of life. They each capture slightly different aspects. So generic quality of life instruments are intended to be broad enough to be relevant across a range of health conditions. For example, the EQ5DY3L that's pictured here, you can see it's quite short, it's only 5 questions long, with 3 options for the response. So either no, some, or a lot of problems in each area. Some quality of life instruments like this one can also be preference weighted, which means they can be scored using an accompanying set of weights that represent societal values for living in a certain health state. So those weights reflect the fact that often people think that some of these areas cause a greater impact than others. For example, having a lot of pain might be considered worse than having a lot of problems moving around. Generic preference-weighted instruments are preferred in health economic analyses because we can use these weights to derive an overall utility score, which forms the basis of the Quality Adjusted Life Year, or QALY. So these QALY estimates are used to inform health policy decision-making and to allow that comparison across different treatments and interventions. Problematically, a recent review of Australian government decision-making bodies found that much of children's healthcare decision-making relies on adult-based evidence. For example, using adult quality of life instruments, which include domains which may not be relevant for children's lives and may equally miss aspects that are important for children's well-being. In some cases, the source of the utility values was not even defined. The authors of that review concluded that much of the decision-making uncertainty in children's healthcare in Australia could have been reduced through the use of a child-specific quality of life instrument. Of the evaluations that are conducted in children's healthcare, very few relate to mental health care, which has resulted in a significant lack of evidence to support the effectiveness and cost-effectiveness of interventions in child and adolescent mental health. So that uncertainty and lack of evidence ultimately risks a misallocation of funds, where some interventions are funded based on unreliable evidence and vice versa. So other interventions are not funded that may actually improve children's lives. So when we think about creating that evidence base, part of that puzzle is having a valid and reliable tool to measure health-related quality of life of children in this population, to feed into those cost-effectiveness and cost-utility analyses. But problematically, there's a significant lack of evidence internationally on the psychometric performance of generic preference-weighted quality of life instruments in children and adolescents with mental health challenges. In particular, there are huge gaps in knowing how these instruments perform head-to-head in the same sample across a range of psychometric properties. And there are real gaps in the repeated measures, such as test-retest reliability and responsiveness to change in health status. So from existing studies, we also don't know whether performance of the instruments differs by child age, gender, type of mental health condition, or self or proxy report. So this is the paper I'll be talking about today. The QR code will take you to the published paper in Pharmacoeconomics. It was part of a special supplement which looks at some other Cochrane project papers, so you can take a look at those as well. The aim of this paper was to examine the psychometric performance of a range of quality of life instruments in children with ADHD and anxiety and/or depression, and to see if that performance differs in key subgroups of child age, sex, self-proxy report, and type of mental health condition. So data from this study were from the Quokka-PMEX study. This was a very large study that collected data on over 6,000 children and caregivers. For my study, I used a subset of just over 1,000 children, which was obtained from an online panel survey. That included about 500 children each, recruited into groups based on a diagnosis of ADHD or anxiety and/or depression. It was an online survey completed at time 1 and then with a follow-up 4 weeks later. The quality of life instruments included in the study were the PEDS-QL, the CHU9D, the EQ5DY3L and 5L, and then a subset of participants also completed the A-6D and the HUE3. But in the interest of time today, I'll just present results for the people who completed the main 4 instruments. The quality of life instruments were completed either by the parent or the child, who also completed the SDQ, which is a widely used mental health screening tool, and a validated mental health symptom measure. So either the SWAN, which measures ADHD symptoms, or the ARCADS-25, which measures anxiety and depression symptoms. So the psychometric properties that we analysed were acceptability and feasibility, so how easy the instrument was to complete, floor and ceiling effects, so the variation and spread in scores that the instruments were able to detect, convergent validity, so how well the instruments correlated with one another, test-retest reliability, so whether the scores remain stable on repeated measurement when there's no change in health status, known group validity, which was looking at how well the instrument can detect differences between known groups. So in this study, we used known groups based on the validated mental health symptom measures using the symptom thresholds, as well as the presence or absence of special healthcare needs. The final test we did was responsiveness to change in health status, so whether the quality of life scores change predictably alongside changes in health status. Now, there are lots and lots of tables in the supplementary material for this paper, and I've boiled it down into one figure just to give an overview of how these instruments were performing overall. This represents the overall performance of these instruments. So each of the points around the hexagon of those 6 properties I just listed points towards the outer edge, represent better performance. You can see that the CHU9D, so that purple line, performs quite well on each of these metrics, followed by the PEDS-QL, which is the pink line, and both of the EQ instruments, the blue and green lines, showed poorer performance for ceiling effects and test-retest reliability, but they showed similarly good performance for known group validity and convergent validity. Now, what isn't shown here is that there was variable performance within the subgroups, so subgroups of age, sex, and self and proxy report and mental health condition. There were relative strengths and weaknesses of each instrument in those subgroups. So for example, for responsiveness, when we're looking at girls versus boys, the CHU9D performed best for girls, but for boys, it was the EQ5DY3L. It was actually more responsive to improvements in health. So it leaves us in a bit of a difficult situation where we've got the CHU9D, which performs quite well overall, but this decision of which instrument to use might differ based on the specific population and the intended use of the instrument. So in this study, we're seeing good performance by the CHU9D and the PEDS-QL, and we could recommend these for use in children with mental health conditions. These instruments showed no floor or ceiling effects. They differentiated most known groups. They showed convergent validity with other health-related quality of life instruments, as well as with validated mental health measures. They showed good responsiveness to improvements in health, and they showed fair or good test-retest reliability. The benefit at the moment of the CHU9D over the PEDS-QL in a health economic space is that the CHU9D has value sets available for calculating QALYs. But value sets are in development for a shortened version of the PEDS-QL, so we can watch this space. Now, in the paper, I discussed some caveats around the choice of instrument, and that includes that there was this variable performance that we observed within the subgroups, and we have that difficult decision about which instrument to use in which population. So we also saw that the instruments had different strengths. For example, while it wasn't the best performing overall, the EQ5DY3L was very good at detecting improvements in health. It just showed higher ceiling effects and lower test-retest reliability. And we also saw that the EQ5DY3L outperformed the CHU9D in some subgroups. But the overall take-home message from this study was that this provides the best evidence to date in international literature on the psychometric performance of generic preference-weighted quality of life instruments in children with mental health conditions. So we found that there are good performing quality of life instruments that can provide valid and reliable information in this population. Greater use of these instruments alongside the treatments, interventions and trials would ultimately improve the evidence base of the effectiveness and cost effectiveness of mental health treatments and interventions, where currently that decision making is made based on subpar evidence. I would hope that better information for decision making would have a positive impact on the types of treatments and interventions that are funded, so that we're providing the best possible care and getting the best possible outcomes for children and adolescents who are facing mental health challenges. So that's it from me. Thank you very much, and I'll hand back over. I'll just stop sharing.
Brilliant. Thank you, Rachel. Perfect timing. And with that, we'll hand straight over to Sam. You're on mute, Sam. You are still on mute.
How about now?
Perfect.
Okay, right, sorry about that. Right, so this is a piece of work we did as part of the SAMA project, which I'll give a little bit of background on in a minute, where we're looking at testing the feasibility and validity of the EQ5DY and CHU9D or CHU9D in a challenging context, which was adolescent mental health in India. So my name's Sam Perry. I'm from the University of Birmingham. I was doing this alongside Harath Al-Janabi from the University of Birmingham, and then researchers from School of Psychology at the University of Leeds, and from the National Institute of Mental Health and Neurosciences in India, which is based in Bangalore. Okay, so in terms of the SAMA project, so this was big project which involved lots of different people from different kind of departments and things. The overarching aim of it was to co-design a suite of school-based interventions to improve mental health and well-being of adolescents in India, and then to feasibility test these interventions in 8 schools in Karnataka, which is the state in which Bangalore is located. In terms of the health economic side of things, essentially, we wanted to see that before the SAMA interventions were rolled out to a full-scale trial, whether or not the standard kind of health economic methods that we would use to evaluate such an intervention in our context would be valid to use in this context. So we kind of focused on both conducting a micro-costing study, which fed into another paper. But what I'm going to be talking about today was particularly looking at whether quality of life instruments that we might use in our context, such as EQ5DY and CHU9D, would be valid to use with Indian adolescents, given the fact that when we did some literature review, neither of these have been utilised before in this population. So thankfully, the previous presentation already introduced these a bit, so I probably don't need to go into the 2 measures in too much detail. But essentially, we chose these 2 measures because they have associated utility tariffs with them, so we could, in theory, derive quality of life scores and calculate qualities. Okay, so what did we do? So the study comprised of 2 parts. The first part was to conduct some think aloud interviews with adolescents in schools in India. So we did these with 10 adolescents back in January 2023. And they came from 3 schools. So it was myself and one of the researchers from NIMANS who went into schools and conducted these. So for those of you who aren't familiar with the concept of a think aloud interview, the idea is that you present the adolescents with the 2 instruments, so the EQ5DY and the CHU9D, and you ask them to complete them in their own time whilst verbalizing their thought process as they do so. So the premise behind that is you can identify any kind of completion challenges as they're doing it, and see kind of what their thought process is whilst they're choosing their answers for it. So think aloud interviews have been used to kind of test and validate other measures before, so such as like the ICE cap, for example, when that was in development. So yeah, we used an error scoring based coding framework, which again has been used in studies before. So this is based on a survey response model, which essentially is a 4-step model that explains how individuals respond to surveys. So using these 4 steps, you can then check against whether the individual is kind of correctly following those steps or if any errors are occurring at any of these steps. So the first step is comprehension. So whether or not the individual is understanding the question as intended. The second step is retrieval. So are they able to appropriately retrieve the correct information to answer that question from their long-term memory and apply it in the correct time frame. The third step is judgment. So can they judge how to use that information? And then the fourth step is response, i.e. formatting that information into a valid response in the model. So for example, not saying I want to choose level 2.5, picking say level 2 or level 3 on these items. We conducted 5 of these using English versions of the instruments and 5 of them using versions in Kannada, which is the local language there. And then we also would have follow-up discussion afterwards where we'd kind of probe any observed completion challenges and also ask the adolescents themselves if they felt anything was kind of missing or if there was too much in the questionnaires or which of the 2 questionnaires, if any, would they prefer. Now, because of kind of time limitations, we only managed to conduct 10 of these think aloud interviews, which ideally we may have had more. So then we supplemented this with some written surveys afterwards, which were distributed to adolescents in other schools. So we collected 164 of these. These again contained the 2 questionnaires, so the EQ5D and Q9D, either in English or Kannada, and they were told that they could choose their preferred language to answer it in. And then we had 6 follow-up questions which closely aligned with those that we asked in the interviews for them to complete, and then did a kind of thematic analysis of the responses to those follow-up questions, both from the Think Aloud interviews and from the quality of life surveys, as well as some sort of basic quantitative analysis looking at things like completion rates and response distributions. So again, I'll focus just primarily on things kind of which are more related to mental health, because I guess that's why we're here, but also just give you a quick overview of most of the key results. So this is the error rate for the EQ5DY during the Think Aloud interviews, so which was 26%, which is very high compared to kind of similar studies, not necessarily using the EQ5D, but looking at validating kind of other measures. Potentially you could see this as being because it's quite a challenging kind of context to use it in adolescents and some of them not answering in their kind of first language, for example. With the EQ5DY, this was the 3L version, and it, as the 5L hadn't been released officially at the time. What we found was the errors were concentrated on the last 2 items. So the first of these was having pain or discomfort. So what we found here in terms of, there were 2 kind of key things. So we added a step to the model for those who were answering the Kannada version of the questionnaires, which is a translated word from English into Kannada conveying the same or intended meaning. And we found that this wasn't this case. So that 4TE is the 4 translation errors that occurred, where individuals just weren't understanding what the translated version of discomfort meant. The other key source of error with this was the individuals were interpreting the question as being to do with psychological pain and discomfort rather than physical pain and discomfort as intended. And there's an example quote there from that. Then the other item that had issues was feeling worried, sad, or unhappy. What we found here was that this was largely retrieval errors. So that's the RTE, which also occurred on having pain or discomfort, where essentially individuals were talking generally about things that would make them sad and then saying that I'm a bit sad when those things hadn't occurred to them today. So with the EQ5DY, they're asked at the start to think about how they're feeling today, but as they were getting further down the questionnaire, they were starting to talk more generally, and we can think of some reasons why that might be the case. So then with Tune-ID, we found a lower error rate, so 19%, which is still relatively high. Picking out some of the highlights. So with pain, again, we had some individuals interpreting this as being psychological pain rather than physical pain. With daily routine, we had individuals who were thinking of kind of things that weren't relevant to the question. So talking about being told off by teachers as interrupting their daily routine, rather than thinking about things like getting ready for school, walking to school, etc. And in the interest of time, yeah, I'll move on from there. But there were a few other things for some of the other items as well. Okay, so then from the quality of life survey completion, we found relatively similar numbers of items missing between the EQ5DY and the Tune-ID, but a slightly higher complete response rate. So in theory, 95% of the Tune-ID responses would have been usable for an economic evaluation. The Tune-ID has 5 levels, and we found that the modal response was still level 1 on 7 of the items, but level 2 on 2 of the items, whereas it was level 1 on all of the EQ5DY items. And as we heard from the last presentation, it seemed to also perform better in terms of ceiling effects. So 17% of individuals chose level 1 for all items in the Tune-ID versus 36% on the EQ5DY. So then just picking out some of the things we found from the thematic analysis. So we've already picked up on this with translation in the EQ5DY and also the meaning of the word discomfort. So when we probed individuals about why they were talking about kind of psychological factors when answering this question, they referred to the fact that discomfort for them was like a psychological feeling rather than a physical feeling. And that was why they were talking about things that would make them sad, for example. With the language, this was quite an interesting point, nothing to do with mental health as such, but one of the adolescent boys was talking about how he couldn't answer the questions daily routine or schoolwork homework because we were interviewing him in the morning and he hadn't, but he'd only just started his day, so how could he comment on whether anything had like impacted his ability to do these things in the day. In terms of preferences between the 2 items, we found the Tune-ID was more preferred, both in the interviews and the surveys. And when we probed individuals on this, one of the key things they felt was it was more comprehensive and relevant to them, particularly with regards to assessing their mental health and emotional health and well-being. And also most individuals preferred the fact that the Tune-ID had more response options. So as I said, it had 5 levels rather than 3. Then some general themes about administering these kind of questionnaires overall, or between the 2 questionnaires. So one of the main things was when we asked individuals again about this kind of talking about psychological pain, some individuals sort of said it would be good to have both very clearly distinguished in the 2, as both are important to them, but there needs to be kind of a specific item for each one. There was a preference for answering in their own language, which is to be expected. And then in terms of comprehensiveness, so when we asked them, do you think everything that's important to you and your mental health, well-being, overall health, etc., has been covered by the items in these questionnaires? Things that were drawn up on were more to do, they wanted to see kind of more capturing their emotions, their mindset, thinking, which we kind of called internal factors, and then also external factors. So obviously things like school and education, kind of parental pressures to do well in school, access to food and how well they'd eaten, kind of social interactions with their friends, and also their circumstances at home. So again, we've got some example quotes which show some of these things. So just to kind of wrap it up, we found the Tune-ID was more feasible. It had a lower error rate and a higher completion rate. The EQ5DY errors were driven by 2 items, which were the last 2. And in our paper, we suggest there are some simple language modifications which would improve feasibility. One of these would be to repeat the fact that they need to think about how they're feeling today, which is something the Q9D does, and we saw very few retrieval errors, whereas the EQ5DY only does this at the start. The Q9D errors were mainly driven by 4 items. I won't get too far into it, but one of the kind of drivers of this was to do with the formatting of the Kannada version that we used, which was absent of some examples for things like daily routine. So it actually might have been even more feasible with an official kind of formatted one. The Q9D was more acceptable, so it was most preferred in interviews and surveys with more relevant content and more response options. Again, particularly, they felt it was better able to access their mental health. And the Q9D had better content validity, but important internal and external factors were identified as missing from both instruments. So just to wrap it up, researchers we suggest might prioritize the Q9D for measuring adolescent quality of life for economic evaluations in India, particularly in the case where we're looking at mental health interventions. But we would also kind of caveat that by saying in kind of different contexts, it may be that any existing kind of quality of life instrument might be missing particular context-specific factors such as like the school and home environment, social interactions and emotions. Thank you.
Excellent. Thank you, Sam. Another perfectly timed presentation. And third and finally, from our speakers, I'd like to invite Tao to present.
Yeah, thank you, Chris. I'm sharing my screen. Yeah. Let me do it again. No. Yeah. Yeah. Can you see my screen?
That's great. Yeah, we can see.
Yeah.
Thank you.
Yeah. Thank you, everyone. And thank you, Chris. And thank you, everyone, for joining me today. So the study that I'm presenting today is about the content and face validity of reference-based quality of life instrument in Indigenous youth experiencing mental health problems. So this year, the joint work with Lydia Sander Eve, Lena Tangsi, Robin William, Pippa Gregory, and Kathy Mihalopoulos. So first of all, some background and motivation for our study. So in the mental health field, choosing an appropriate health-related quality of life measure is quite challenging. The literature has well reported that the commonly used measure, for example, the EQ5D and the SF12, are not sufficiently sensitive to some mental health problem. So especially the EQ5D were criticized for its focus on physical health. And we know that for youth, physical health is at their best. So it further question the suitability of EQ5D in youth with mental health. On the other hand, the ACO-60 is an Australian-based measure, and it has extensive dimension covering the mental health and psychological distress. There are a few applications in youth in general, but its validity in youth with mental health remain unclear. And indeed, our systematic review published in 2022 also found that no existing health-related quality of life measure has sufficient psychometric evidence in children and adolescents aged up to 25 years. And recently, the Recovering Quality of Life, or the RECOL, is a newly developed measure specifically designed for people with mental health age 16 and above. However, its psychometric evidence is limited to some population, for example, the UK or the Hong Kong general population. So it requires further psychometric testing in other population as well. And in Indigenous testing, there are further concerns in terms of the appropriateness of the existing health-related quality of life measure, because these measures are based on the Western principle of health with a focus on individual health. However, for Indigenous people, there is evidence that their concept of health is different. It includes both the individual health and the whole of life view that include the social emotional and then cultural well-being of the community as well. So these concerns raise a big question whether the existing health-related quality of life measures are appropriate for use in Indigenous youth with mental health problems or not. This is a big question. So in this study, we only aim to explore the first step of examine the psychometrics testing of these preference-based health-related quality of life by investigating only the content and face validity of this measure in young Indigenous people experiencing mental health problems. So in terms of methodology, because we are doing this for Indigenous population, we embrace the Indigenous research methodology where we adopt the yarning approach as a way to conduct our qualitative study. So indeed, so specifically, we conducted yarning interviews or yarning circle with a topic guide based on a cognitive debriefing approach. So in terms of the eligible criteria on the Indigenous young people aged between 15 to 25 years with history of at least one formally diagnosed or undiagnosed mental health issue will be eligible to participate in our study. So in total, we recruited 20 participants participating across 8 individual yarns and 5 yarning circles. These yarns lasted between 12 to 16 minutes, and we conducted these yarns in Perth or Bundaberg in Western Australia. In terms of data analysis, we adopted the thematic analysis for qualitative data. So before I briefly talk about the results, this table just show you the measure that we use in this study. The first measure is EQ5D5L, which has 5 items covering 5 dimensions: mobility, self-care, usual activity, pain, discomfort, anxiety, and depression. For SF12, it has 12 items covering 6 dimensions as well, and I would skip these dimensions. ACO60 is the longest questionnaire with 20 items covering 6 dimensions as well. And for the recall, we use a recall 10 with 10 items covering 7 dimensions. Based on the data that we collected, 4 main themes emerge. They are appropriateness, comprehensiveness, comprehensibility, layout, and format. So in terms of each theme, there are several sub-themes as well. So for example, in terms of appropriateness, there are 4 sub-themes, including mental health relevance, culturally appropriateness, age appropriateness, and sensitive or judgmental question. So the table here can show you that the positive comments will be illustrated by the plus sign here, and the negative just indicates the negative comments that we received from the participant, and the slash is for missing item. So in terms of the mental health relevance, all 4 received some positive comments, but the 3 measure ACO60, SF12, and EQ5D5L received the negative comment, except the recall. It doesn't have any negative comment for the mental health relevance. So for example, in terms of the ACO, it says it has one participant mentioned, if I feel good because the question is somewhere like the main thing, cover the main thing about the mental health. For SF12, participant mentioned, I think it's good that like when I talk about emotion and daily activity, like how is it impacted your daily life, because people might not even realize that until that they are actively I'm not getting out or doing what I'm usually doing, so that's good. Sorry, I'm just moving around the the participant pain because of my code. So in terms of the recall, the participants mentioned that I think that they are given a better focus for mental health, and then they are also having the physical in there as well. So like you can say this is more aimed at mental health, whereas the others are not. So they have a lot of positive comment for the recall in terms of the mental health relevance. In terms of in terms of the negative comments, the ACO 60 it received the most negative comment, where participants mentioned that there is not really a mental health focus for only 4 questions on mental health. It's not a lot. In terms of SF12, participants mentioned that in terms of the physical health, they think that it's not really relevant to mental health, because in terms for the people with mental health, you could be physically capable of doing it, but mentally are not able to do it. In terms of EQ5D5L, they said it's great how quick it is, but this is not a good tool. There's just not enough information about mental health. Culturally appropriate, only the ACO 60 received the negative comment in terms of this theme, where you can see on the screen here the question 6 about the relationship between your health and your family, and then they said, if you are doing it for Aboriginal people, it's going to be a holistic approach. So say in my health, physical health, mental health, like, oh, I have a broken leg, so my relationship with my family is now different. So I need to get people will treat me differently. I have to get help. I can't go anywhere. It just like reflect the how the relationship, how the people in the indigenous setting are related to their family, and it's going to be changed if there is anything happen to them. It doesn't necessary to be negative way, in a negative way. In terms of age appropriate, a lot of comments are on the wording of the in the questionnaire, where the participants think that, for example, in the ACO 60, in terms of the question getting around, they said, how well can you get around? That's a dumb question. I mean, how did I, as a young person, like that? So they feel that it doesn't apply to them. And for another example, in EQ5D5L, is most of the stuff about the old person. That not much young people go through this type of stuff. In terms of having sensitive or judgmental words or question, again, the ACO 60 received the most negative comment, where, again, an example here in the question 6, about the impact of your health on the relationship with your family. One participant think that the reverse can occur, where they mentioned, does your health affect your relationship with your family life? Does your relationship with your family affect your health? Because that a lot of Black family, especially when it comes to mental health. Regarding the recall, there is one question that can be triggering for participants, which is the question 6 here. I thought my life was not worth living. So participants said that can be triggered, and especially when it comes out like that. So in terms of comprehensiveness, there are quite a number of missing items that participants proposed to add to the measure. But like one particular factor is the community or culture factor that they think that can be relevant to all the measure here. In terms of the comprehensibility, the SF12 is received the most negative comment, where you can see that like the question can repeat itself a lot in a lot of questions, so that can create confusion for participants. In terms of ambiguous item, the ACO 60 again received the most negative comment, where they mentioned that like the example in the bracket that really confusing to them when they had to read the question again and again. in another sub-theme layout and format, the length, the ACO-60 received the most negative comment because this is the longest questionnaire. And participant mentioned that when people with mental health, they are going through the tough time, the last thing that they want is to read a very long questionnaire like that. And in terms of the layout, the recall receive a lot of positive comment in terms of its layout with the table and with short sentences. So based on our findings so far, we concluded that the recall is the best available measure for assessing Indigenous youth mental health related quality of life so far. And on the other hand, the ACO-60 were perceived as less sensitive, having detrimental items, having some culturally inappropriate item and unsuitable for youth. The EQ-5 fail were criticized mainly due to its lack of mental health focus, and the FF12 were criticized due to its lengthy question and complicated question. So based on this finding, we recommended that further work should be done on the psychometric performance of the recall in Indigenous youth, especially in terms of the conversion and non-group validity. So thank you.
Excellent. Thank you, Tara. All right. And that's it. We've had our 3 presentations from our researchers. So I would like to hand over to Tessa now to lead the discussion.
Thank you, Chris. And thank you so much for those 3 excellent presentations. It's really great to see the attention to detail that's being placed on kind of improving measurement. Can I just encourage everybody to ask any questions? If you would like to put anything in the chat, that's great. Or if you want to raise your hand and you can kind of ask your question verbally. So I just want to say a couple of things about each of the presentations and maybe raise some fairly challenging questions, so which hopefully we can all join in on. So just starting with Rachel's presentation around some of the analysis of the PMIC data in Australia. It was, beautifully clear, well-motivated presentation. So I guess I'm just kind of going to go straight in with a more challenging question. One thing which I think is quite interesting in drawing some of the conclusions that we might make about the differences is we don't necessarily set hypothesis around what we might expect to see for a particular subgroup. So I guess I want to raise the challenge as to how much we should draw from any single study on finding a particular difference between an instrument for a particular subgroup, unless we've set an a priori hypothesis that that's something that we should expect to see. Just a couple of points, maybe, Rachel, that you could clarify around the data that you used in the hexagon. And I thought that was a really neat way of showing a lot of data in a beautiful visual way. I guess I wasn't quite sure about how you judged the 0 to 100 on the actual drawing of the hexagon. And the other thing I thought might be interesting for you to bring into the reflection is, should we be thinking about weighting any of this evidence? Is some of the evidence more important than other bits of evidence? And Linda also asked in the chat if you could say a little bit about whether or not we find the same relationships when we're looking at the self-reported data compared to the proxy reported data. So maybe, Rachel, if I could give you a chance to respond.
Yes, thanks, Tessa. I might just pick up the question that was in the chat first, and then I'll get to your questions as well. So thanks, Linda, for the question about whether we did self or proxy report. The answer is yes, we did look at self versus proxy report for this study. Gosh, that's bright on the side of my face. Sorry about that. The challenge was that in this study, it was either the child or the parent proxy who completed the instruments, which meant that we actually had a different set of children in each group. Now, the parent, we wanted to encourage the children to complete it themselves. They couldn't complete it if they were under 7 years old. So all of the young children we have parent proxy report for, which means that we've got a more heavily weighted proxy reporting who's for the younger children. And we also gave the parent the opportunity to say whether or not they felt the child was able to complete that themselves. So for whatever reason, if the child was really unwell that day, or they were in hospital getting treatment, or if the parent felt that the child just cognitively was not able to complete the instrument, then it was the parent who completed that. So we actually have different sets of kids between the child self-report and the parent proxy report. So in our study, despite those differences, we actually found that the self and proxy report came out quite similar. So we're actually finding that they were fairly similarly rated as easy to complete. They were both able to detect the known differences. They both had good test-retest reliability across these different subgroups. So self and proxy in our study came out quite similarly, but I want to just give it a bit of a caveat that they're actually different subsets of kids. There is another Quokka study that had a dyad sample. So there was a sample where they had the child and the parent complete the instrument. So the child and the parent for that same child completed the instrument, and they looked at all of these psychometric properties in those dyad samples. So I'm actually going to pop that in the chat because I think that's probably worth having a look at. In terms of self and proxy, it probably, if I can say, would be a better indicator of the difference between self and proxy than the study that we had for this sample. Some of the other questions from Tessa. So should we weight these findings? Is a really interesting question. And I think that comes to me from this, what are we using it for? So what context are we using this instrument in? Are we talking about a clinical context where maybe the responsiveness to health improvements or worsening in health is more important than the other factors, the other psychometric properties? There might be instances where we don't care about ceiling effects so much. There might be, in a study where we actually want to see really reliable scores over time, then test-retest reliability is going to be interesting. So I think if we were looking at weighting it, that would be due to the context of why we're capturing the health-related quality of life information. So could we weight them overall for every context? Don't think so. But I think if we had some different contexts and different interests, then that would be where we start to look at each of these psychometric properties differently. Don't look at the overall performance of all of them and just say this one performed well in all of those things. Maybe there's an area that we're more interested in, then you might choose a different instrument, I suppose. On the question about the hexagon, how did I get from the 0 to 100? So there were a range and a number of tests that came into each of these psychometric properties. So for example, the known group test, that was 4 different tests. And I did 0 to 100 based on the proportion of those tests that the instrument passed, essentially. So if it got 4 out of 4 known group, it was able to detect the differences between those known groups on 4 out of 4, then that's 100%. But if it got 0 out of 4, that's 0%. So the 0 to 100 is essentially the proportion of the tests within each of those categories that the instrument passed, if that makes sense. Which is a little bit like clunky, because if there's only one test, then it's 0 or 100, but it didn't really come out as one test because we had lots of subgroups as well. So it includes all of the subgroups. And then the clangor of the question of how do we interpret the differences between the subgroups of when we don't really have a hypothesis on whether there should be differences? It's a really great question. I don't think I have a good answer to that. I think we were exploring lots of different subgroups because, well, for one, the self and proxy, we knew that there would be differences between the self and proxy report because previously people have found that self and proxy are not very well correlated. So we were expecting to find different performance, and actually we found similar performance, which was a bit counterintuitive. And for things like gender, I guess, that would be one where we weren't hypothesizing a difference at all. And it was more about that we know that the quality of life between girls and boys is different. So does that affect then the performance of the instrument? Because we've got poorer in terms of mental health performance in adolescent girls, for example. So I guess it was more of an exploratory one, that one, and I don't know whether anyone else would have some thoughts on how we interpret that. Tricky one. Thanks, Tessa.
Thanks, Rachel. Please do raise your hand or put any questions or comments in the chat. So I'd just like to move on to Sam's presentation, which again, really interesting and really great level of kind of rigor of the qualitative analysis. I guess I wanted to kind of sort of really, partly for my own interest, but ask you to say something about how challenging it was to be consistent between coders when you're breaking down your breaking down into comprehension, retrieval and judgment, and was it difficult to be consistent in that respect? So that's something I'd like to comment on. But I was also wondering if you could comment a little bit on the sample size, and whether or not, because I know, if we take Cosmin guidance, it's kind of 7 if they're very similar, and you had 10, but it does seem very small if what the final kind of take home message is based on percentage difference of error rate. So we're kind of using a sort of qualitative sample size, but in a sense switching it a little bit to quantitative findings. So and the final thing I think is something that Rachel just picked up on, which is kind of how much do we actually worry about the ceiling effect? Because that was obviously one of your big differences between the groups. And if we have a mental health population who might not currently be experiencing any mental health symptoms, even if they have in the past had a diagnosis or problems, but on that particular day they might be possibly in full health. Should the ceiling effect be something that we are worried about when we're thinking about using this for policy with respect to resource allocation decisions, not necessarily individual clinical decision making?
Okay, thank you. I'll take those one by one then. So in terms of how challenging it was to be consistent between coders, so we had 3 of us who did the coding. One of them was Harith, who has done similar studies before, using so he developed the IceCap measure, for example, and he used it for that, which is where we kind of drew on the methodology from. So I think me and him had discussions before, and I think we were fairly consistent with it, but we also wanted to bring someone external in as well. And sort of we gave them the information on the framework that we'd be using. So as one of the researchers from the School of Psychology in Leeds. And then collectively we had a kind of post-coding meeting, if you like, where we went through how we'd coded like each segment basically of it. And we generally found that we were pretty consistent throughout. Off the top of my head, I can't think of exact figures, but I do have a big Excel spreadsheet somewhere where it shows what where we did have differences. Generally, we resolved that through kind of mutual agreement after discussion. So I don't think we were like wildly far off from each other, because I think it is quite it's a framework that has been used before, and if you sort of know about it or have read other papers on it, then you can kind of see how it has been done before. I think there are occasionally some differences maybe in interpretation of where there's clearly been an error made, but what sort of error does it kind of fall under? So I think one of the main things was about whether they've answered the question kind of generally rather than talking specifically about how they're feeling today, whether that is kind of retrieval in the sense that they have retrieved the information but not for the time frame that they're thinking of, or whether it's sort of a judgment error because they know the information but then have kind of judged incorrectly how to use it. I think that in previous studies has kind of varied. So some papers code it as a retrieval error, some papers code it as a judgment error, but I think if you're just clear in your justification as to why you've done it one way or the other, then that's all right. So the second question was about the sample size, right? Was that referring to the survey we did rather than the Think Aloud interviews, or?
No, sorry, it was the Think Aloud interviews.
Yeah, so I mean, I think honestly we chose the sample size. Well, we just went in. I was in India for 10 days doing other things as well and leading the Think Aloud interviews with one of the researchers from NIMANS, so the National Institute of Mental Health and Neurosciences, was there with me, obviously, for translation reasons as well. On some of those days, we're also doing other things, so it wasn't like we basically chose get as many done as we can, and we'll just have to work with that because the feasibility, obviously, of going back out and doing more if we needed to wasn't there or wasn't budgeted for at all. So yeah, I mean, I said it's quite a small sample size compared to other studies. So I think they tend to aim for more 20, 25 sort of Think Aloud interviews to get more data. I mean, I'm going to be on another project very soon conducting Think Aloud interviews, and we're aiming for about 25, and that's a figure that's been used before. So I don't necessarily think that we could claim that like data saturation was completely reached with the sample that we used, but I think we still got a lot of very interesting insights from it. And then that's why we also wanted to kind of supplement it a bit with some basic kind of quantitative analysis through those surveys and try to design those surveys. So although we weren't there, we could ask similar questions that we were asking in the follow-up discussion to kind of draw on what the answers to that were from also what we had from a more in-depth discussion after the Think Aloud interviews. But yeah, I mean, again, the sample size wasn't ideal, but it's what we had basically.
Yeah, absolutely. Sam, in the interest of time, I might just allow you to kind of think about the question around ceiling effects afterwards, and move on and just say a couple of things about Ty's presentation, which again, super interesting and really kind of rigorously presented analysis, which is great. One of the things I was particularly interested in, Ty, is your use of the yarning as an approach and the yarning circles. And I just wondered if you could tell us a little bit about how that differs from a more standard cognitive debrief interview or from a kind of focus group, both in terms of how you approach the kind of planning stage and developing the interview prompts, but also how you approach the analysis as well.
Yeah, great. Thank you, Tessa. So yarning has been a like is it a conversation approach that have been used for the individual indigenous population, and is so in yarn is it different from the formal or like the usual interview approach in a way that it allows the participant to freely express their opinion. They can tell the story, and then the researcher just sort of like just to move along the conversation. But then because of like in a conversation style like that, like people can tell the story, but then sometimes they can tell part of the story and then not the part that they don't want to tell. So that the interview guide that like we added into our study just to make sure that the researcher sometimes like just guide the conversation a little bit, just on to make sure that like it is on the topic of that we are exploring for the research question. And in terms of like how to conduct the yarning, this is based on a very long-term relationship between our indigenous researcher with the community. So these yarnings were conducted by our indigenous, actually one non-indigenous researcher and one indigenous researcher, but they have been working with the community for like more than 10 years. they have been introduced to the community, not just only the participant, but also the participants' family, parents, grandparents, and then also the elders in the community. So they have a very long-term communities relationship that build trust and relationship with the participants. So that's really a very high level of trust between the researcher and then the participant there. And then another part of your question is how I did the data analysis. So in terms of the data analysis, I would use the normal data analysis approach that have been adopted in other qualitative study, where I combine the data with the transcription and then also the interview note from our researcher, because our researcher have a very detailed note on in terms of the facial and then non-facial, like non-verbal cue from the participant as well. So that is combined just to analyze the data. Yeah, so hopefully that answers your question.
Yes, thank you. And just one final question. Do you think there are any lessons from adopting a yarning circle and yarning approach that we could draw on for more in the context more broadly, not just with Indigenous people?
I guess the one thing that I learned from this they are like, when you trust the interviewer or you trust the researcher, it open a lot of door for discussion, open discussion and open suggestion, and a lot of like that like our participants. What I find very fascinating is that like the level of intelligence, like in from their responses. Can you hear me? So that's the one thing that like I think that like if like we can do that in all of the qualitative study, that we have a sort of like build trust with the participant rather than just like email or approach the participant and then, hey, I have this study and I want to interview you in a very short like we normally don't have a lot of time to build rapport with our participant. That is something that like maybe that people can reserve from sharing their opinion, I guess. But then again, we need evidence for that.
Great. Thank you, Tan. And once again, thank you to all three excellent presenters.
Yes, thank you, everyone. And thank you very much, Tessa. Thanks, everyone, for sticking with us for a few extra minutes. Yes, as I said, if you're not a member of the SIG yet, please join us. But otherwise, thanks again to everyone, and we'll see you at the next one.
Thanks, everyone.
Thanks, everyone.
Thanks.